Thanks, Brittany. We appreciate the support from the Association for Maternal and Child Health Programs to make this roundtable discussion possible. As many of you know, AMCHIP received some funding through the COVID Act that enabled them to fund a number of projects about a year and a half ago related to expanding telehealth applications in EHDI programs. And these roundtable sessions are a follow-up to those funded projects. They're sponsoring a number of them, and we really appreciate their support to be able to do this. With me today on a panel of people that will present at the beginning of this are 5 people who have been involved in telehealth applications in one way or another. Stephanie McVicker, who is the EHDI coordinator in Utah, Sarah Stone, the EHDI coordinator in Massachusetts, Kira Kirshner, who is a parent from Utah who has received telehealth services for her son Cyrus, who is also with us and may chime in some during Kira's discussion. Brant Culpepper, who's the EHDI coordinator in Georgia, and then Jessica Messersmith, who's a professor at the University of South Dakota and a member of the Joint Committee on Infant Hearing. So each of these 5 will be talking about some of their experiences with telehealth and some of the challenges that they've encountered, as well as some of the successes and some of the lessons learned. We're hoping that this will be a very interactive roundtable. That's why AMCHIP designated them as roundtables instead of webinars. We are not planning to present information for the whole time, but we hope that the presentations that we have planned will stimulate some ideas and questions and perhaps some of your own experiences that you would like to share with us. If you have things that you would like to say, raise your hand or put something in the chat. Brittany will be helping us to monitor that. And if we don't recognize that your hand is raised or you put something in the chat, just take yourself off mute and speak up. We're among friends and hope this will be a vibrant discussion that people will be able to share their ideas and as well as some of the frustrations that they may be having with telehealth applications. What we hope this will do is to create a community of people who are involved in telehealth in one way or another and can reach out to each other to get assistance. So just before the meeting convened, I went through the registration list. We have people from 31 different states and territories registered for this. And so there's clearly broad interest, but I think there's also broad experience represented in this group. So don't be shy about speaking up and asking questions or making your own contributions. So let's start first with Stephanie McVicker from Utah. So Stephanie, we'll turn the time to you. I think you're going to share a screen.
I sure am. Let me go ahead and do that. Let me go into slide mode. I just have a couple of visual aids. So as Carl said, I'm Stephanie McVicker. I'm the EHDI director in Utah, and we have 3 EHDIologists, so EHDI audiologists on our EHDI team, and Shannon Winneck and Jenny Pedersen are my 2 wonderful colleagues. And because I've become, unfortunately, a lot more administrative than clinical, Shannon and Jenny do the bulk of our tele-ABRs at this point in time. So I need to acknowledge them and their continued amazing clinical prowess and dedication to our families. So this picture here is down in southern Utah and central and southern Utah. We have a beautiful, beautiful state. I highly recommend you come visit if you haven't been there. But part of the beauty of our state is we have a lot of rural and frontier areas where there are not a lot of people per square mile, and we only have infant and pediatric audiologists in the strip of the population along the mountains and the Wasatch Front, centered around Salt Lake City, to Provo in the south, and then up to Lake Ogden and Logan in the north. And then we have one or two down in St. George, which is on the way down to Vegas. So we don't have a lot of infant and pediatric audiologists. So we've been doing teleaudiology for about 10 years now. We started with a pilot project in 2012, and we worked with a midwife who, she was great. She was one of our midwife EHDI champions for newborn hearing screening. And we thought, okay, we need to get services for our babies that are born in the frontier and rural areas of our state. We need to be able to provide ABR services where they don't have to drive 3 to 5 hours to get services, take time off of work, try and get childcare and things like that. And because of the barriers that were present, and many of them don't have insurance, we found that there was a lack of follow-up. These babies were lost to follow-up, and they didn't get the audiological diagnostic evaluations and the services that they needed. And so when we first started in 2012 with our midwife, right in about the central part of our state here in Mount Pleasant, we did it in her practice, which was in her home, and we utilized Wi-Fi. And I'm going to talk about the problems with that on the next slide. But this is our current state of affairs for our tele-EBR system. We had our original sites, the little green smiley faces, up in Tri-County and then down in San Juan County. And then our newer tele-EBR sites that we received some AMCHIP funding to increase telehealth because of COVID. I think it probably was 2 years ago or maybe 18 months ago. We were able to expand our remote sites to some other areas across our state, and those are represented by the blue smiley faces. So you can see we have several sites that are going across our state where the EHDI audiologists provide diagnostic auditory brainstem response services. And here's a picture of Shannon. There's been a lot of teleworking since the pandemic, and so there she is in her own office. She has 2 screens going on. She's got the ABR waves from taking over the computer down in, I think she was down in Blanding in San Juan County when she was doing this one. And then she has another screen going where she interacts with the families for the video conferencing part. So here's a couple of key tips that we've found over the past decade. Remote diagnostic ABR testing works like a charm. It's fantastic. You really need to have wired internet connectivity. If you don't have good Wi-Fi, you're setting yourself up for a lot of frustration for you and your hostess or host at your remote site, and obviously for the family. And you really need a champion at your remote site. So if you're going to set up a teleaudiology service, you need someone who is going to take ownership of the project on the remote end. So it took a while for us to get those champions in place. Once we had someone who took ownership of the project, meaning they helped facilitate the scheduling with the patients. They were trained, and they were the one that most of the time are the ones that are present during the testing because they know it inside and out, how to prep the baby and put the electrodes on and things like that. Once you have that in place and the buy-in, it's really exciting because it works great, and you know you're providing a great service for the families. You're going to need something to do remote desktop control. So we purchased VivaSonic ABR equipments that are placed across the state at the remote sites. And then we have our 2 laptops going when we're doing the test as the host back in Salt Lake City. And we use a program called BOMGAR, and we take over the VivaSonic unit itself. So you actually then are, running the test and looking at the waves and everything on your laptop. And then we have our video conferencing laptop going so we can talk to the family and the parents like we were in the room with them. We get a history, and then we give results and all that kind of great things. So the video conferencing, we hook up through the Utah Telehealth Network. I think a lot of states have a telehealth network, which is a fantastic thing because they provide technical support and resources, and we use their Zoom account. So when we hook into the UTN to do the video conferencing, We do connect to the family through their private and secure Zoom line. It's really important that you have a nice environment for the test room, free from any electrical interference. And don't forget, because you don't have the VivaSonic in your possession, when you finish the test, all your waveforms are on the VivaSonic machine at the remote site. So make sure that if you want to look at your waveforms later and analyze them a little bit further, that you set up a time with your remote site where you can hook up again, take over the equipment and review and mark your waves if you haven't done it during the test. Electrodes, we usually do about 2 to 3 per month. And the electrodes, because they're not used an awful lot, just be careful, they can dry out. So we always have the sites put them in a Ziploc bag. We also have a little bit of gel if we need to wet them again, because we have found that if there's a long time between babies, that the electrodes are prone to dry out. And then I just wanted to mention about insurance coverage. We have been able to provide this service as a public health service, so we do not charge for our services. And in our state, audiology is not a recognized provider of telehealth services. And even though it's in our scope of practice on the national level as audiologists, without being recognized as a provider in our state, insurance will not cover the services. And so that has been a barrier in that we've talked with our community and our private audiologists and given presentations and told them how great this is. And, you know, you could do this with your families. And they're always like, this is great, we want to do it. And then it gets stopped because of reimbursement. So you would definitely want to find out what's going on in your state, because that could be a barrier. And we're just really lucky that we have the support of our bureau and division director that allows us to provide this service to our families. There's been so many great things. We definitely have seen an increase in the follow-up rate for diagnostic and meeting that 3-month milestone. And you get happy families and happy hospitals. The hospitals that are the sites, they love it that they can provide this service to their families. And the families are really happy because, one, well, we're free, but also it saves them a lot of time and stress and effort in terms of having to drive up to the Wasatch Front to get their services. And this is just a picture here of the little telehealth suite we have set up at Uinta Basin Hospital in Roosevelt, Utah. And then this is Jenny. This is when we went down to Blue Mountain Hospital in San Juan. It's very close to the Navajo reservation. So we do serve a lot of American Indian families through Tele-ABR down there. This is when she and I went on a road trip to go and do our training for the Tele-ABR. This is Shannon on one of the telehealth carts at one of the hospitals. So it can just be on a laptop, or some hospitals will have an official telehealth cart. This is the suite at the bottom. This is a setup down at Blue Mountain Hospital, a dedicated area where we do the Tele-ABRs. And then here's one of our little babies from the reservation, just resting very comfortably in their little portable crib on the bed. And this chokes me up. This is a picture that we had taken just a couple months ago. And this is what teleaudiology is all about. This was a medically fragile child down in the Moab region of our state near Arches National Park. We're in the time of COVID, and they were able to get their diagnostic audiological evaluation. There's Shannon on the screen. Here's the nurse at Moab Regional Hospital. And we were able to get this little girl a very timely and quick diagnosis and start getting her the intervention and services that she needs. So I just absolutely love the picture because it really captures what it's all about. But anyways, I'm Stephanie. Feel free to reach out at any time. This is my email address, smcvicker@utah.gov.
And Stephanie, I just wanted to flag, we had one question come in. When you were using a midwife's office for remote site, were you completing follow-up for home births? If so, were you doing screening or diagnostic ABRs?
That's a great question. And so the we had given equipment, screening equipment to the midwife. So the midwife was doing the screenings. So we were providing the follow-up on the failed screenings by completing the diagnostic ABRs.
Well, thank you, Stephanie. That was a great presentation, and appreciate all you've done for 10 years. So that's a long time for doing teleaudiology. Any other questions or comments from people out in the audience?
It looks like we had one more come through from Paul. This is wonderful work. Congrats. Question, is this scalable to a much larger level? Big question.
Yeah, I really think so. We weren't sure how successful it was going to be when we did our proof of concept test, and it works wonderful. It's great. And if you have a site, even like at a local health department, a lot of them have telehealth suites nowadays. Certainly a room in the hospital, many hospitals are already set up for telehealth. It lends itself really well for you to be able to provide these services for these families and babies. And I know there's other states that are out there that are also doing the diagnostic tele-ABRs as well. And I know that they're also finding success. I see there's another question that just came in. Let's see, from Jenny. No, we haven't done one in Wendover, Utah. No, but that would be a good place to do it. And then Jenny asked, where were you trained for tele-ABR? Is that something available to all audiologists, or was this local to your state? We did not receive training. So we just kind of worked with NCHAM, because we're really lucky because they're in Utah as well. And Carl was kind enough to let us use his technical consultants, and they helped us figure out the setup, what was required, what kind of remote desktop control was recommended, and then actually helped us when we did our test runs and things like that. And so we just kind of learned as we went along. And again, we had the expertise of Carl's team at NCHAM to help us with our pilot project. And then we've met with audiologists in our state and done presentations and everything to show them. We would love for it to be taken over by the community and the private audiologists. And I think with an increase in telehealth services because of COVID and the efficacy of it being seen, I'm hopeful that there will be insurance coverage in our state at some point. And I would love to hear about the other states and see if your teleaudiology services are being covered. The facilitation fees are being covered at the hospital end. So the nurse that is at the remote site facilitating and doing troubleshooting and staying with the family and hooking up the baby and all that, they can bill for a facilitation fee and get paid for that. So that's helpful for hospitals to be a remote site. It's just that if it was a private audiologist, they're not getting reimbursed for their time, which luckily, we're doing it as a public health service.
Jessica, why don't you jump in with your comment that you put in chat?
Absolutely. Thanks, Carl. I had added in the chat that as tele-ABRs and tele-infant assessment is becoming more common, there are AUD training programs that are including their students in that. So for example, at the University of South Dakota, our students are involved in tele-infant assessment, and through their coursework in clinic, they learn the process for setting up those platforms and integrating with them. So I think you're going to be seeing some new grads coming out who do have this skill set.
Great. Any other questions? One other logistical item I should have mentioned at the beginning, but you're all old hands with Zoom, so it's probably almost unnecessary. But if you would like a live transcript, at the bottom of your screen, there's a little button that says CC on it. And if you click on that and then pick the option that works best for you, there is captioning for this. And that'll be part of the recording, I think. So okay, Stephanie, thank you once again for a wonderful presentation. And I know you have some other scheduling things that if you have to leave, we understand, no problem, okay? So let's turn the time now to Sarah Stone, who is the EHDI coordinator in Massachusetts.
All right, thank you, Carl. I am going to share my screen. All right.
Looks great.
Okay, so I'm Sarah Stone. I am the EHDI coordinator for Massachusetts, and slides are not advancing. Let's see here. I'm going to stop sharing and I'm going to try again. It might show up as
Shows up with the little slides on the side now, but.
And there we go.
Yep, you got it.
I think I was on a PDF version and that's why it wasn't working.
Okay.
So it's, it's amazing to be here presenting about this because, listening to Stephanie and you'll hear from Brant later. Those are the people that I looked to and said, well, why can't we do this? As Stephanie's been talking about, Utah did this for 10 years and had a great model. So in Massachusetts, it's, we're a little different. We definitely don't have, the rural and frontier areas. We're a small state geographically. But as you can see on this map, it's obviously, it's small, but there are huge swaths of the state that don't have any services. And Cape Cod and the islands are sort of on the right-hand side. And you can see that the representation of the plus signs is basically, it's diagnostic centers that will see babies after referral from a newborn hearing screen. So a lot of concentration around Boston, some areas in the Southeast, once you get to Central and West, much fewer. However, none exist on the Cape, Nantucket, or Martha's Vineyard. And we found a higher loss to follow-up rate in Barnstable County, which is the mainland of Cape Cod. It was 8% was the loss to follow-up rate versus 1.6 in other counties in the state. So in this region, there are now three birth hospitals. Two were on Cape Cod proper, if you will, so Cape Cod Hospital and Falmouth, and then one on each of the islands, Nantucket and Martha's Vineyard. But as you can see, it doesn't add up to a heck of a lot of births. And from these births, looking at the referral rates of 2%, you'd probably end up with about 25 referrals per year. So this has been a historic problem. It's something we've talked about. We thought, strategized about different ways that we could approach it and ways to affect, positively and impact the loss to follow-up rate in especially that area of the state. So once we started thinking about the possibility of teleaudiology, we talked to the diagnostic centers, so the audiologists, to see, were they interested? And surprisingly, we didn't have a lot of takers. Even, with COVID, telehealth services were not heard of, prior to COVID for most, providers in Massachusetts. And as with many medical centers, could say, well, you come to Boston for that, right? So there was a lot of folks who we reached out to, and they weren't real sure if this was something that they wanted to get involved in. Thankfully, we were able to find a partner with Boston Children's. And then the second step, as Stephanie was alluding to, identifying the spoke site and the commitment to not only the personnel at that site, but also the administration of those sites is tremendously key to the success. The site that we identified on the Cape was actually the remaining birth hospital, Cape Cod Hospital. And we felt that it was important we looked at many different sites. We looked at EI centers, we looked at all kinds of places where families go. And we identified Cape Cod Hospital, partly because as the birth hospital, they would have the majority of the referrals. Families also obviously felt comfortable and were able to get there. And they happened to be located in the town in which the ferries come in from both Nantucket and Martha's Vineyard. So the geography of that was key to us. And having those folks that are, committed to this process is so instrumental. We had folks both at Cape Cod Hospital and at Boston Children's who were extremely dedicated to making this happen. But as dedicated as those audiologists or nurse managers might be, they also needed the buy-in, from their administration to make this work. Because unlike Utah, Massachusetts does not have public health audiologists. This was all privately done. So it's a very different model than what I had seen sort of in other states. And maybe I was a bit naive about how it could happen, but we absolutely made this work. So a lot of the things that we had to deal with and were all these detail things. And all of the questions that I have up on the screen were absolutely answerable. They were just things that needed to be considered and agreed upon between all the parties. Who owns, maintains the equipment? Who's going to pay for that? Who's making the appointments? How is it working with credentialing? With our spoke site, Cape Cod Hospital, they did not have audiology on site. So the audiologist at Boston Children's actually had to get credentialed by Cape Cod Hospital so they could bill. Whose medical records utilized? Whose kid is this, right? Can it be billed? In that case, who's doing the billing? How are staff trained and who's paying for that training time? So these were all things that we absolutely were able to work out. And what ended up happening is Cape Cod Hospital is paying a fee for each child to Boston Children's, and Cape Cod is billing insurance for the testing. So that's how we've worked it out thus far in Massachusetts. So some of the successes, like we could do it. It is possible. And it's a sustainable model because insurance is able to be billed. Appointments are now open to all the birth hospitals in the area. We'd started out small with just Cape Cod, and now it's open to Martha's Vineyard, Nantucket, and then other area hospitals as well. If folks who live on the Cape, it's like, do I have to cross the bridge? Like, I don't really want to have to cross the bridge. And so that was part of the problem with the loss to follow-up prior to this program. But we've also found, they have identified at least one child with reduced hearing, and the family was, much more amenable to crossing the bridge once they knew that there was further testing that needed to get done and further services that were needed. And as Stephanie had said, families and pediatricians really like this. There was a time last year where the program was not operating because they were working out all those logistics and the billings. And pediatricians were reaching out and saying, hey, what happened? We really enjoyed this. We really liked having the service. Families really liked it. What can we do to make this happen again? So it was good to know that they were so satisfied with how the program was working. Some challenges, just, some of it is just getting to know each other better. So the communication between like the on-site nurse and the remote audiologist when the family is present, just working out ways to signal to each other that there's things that might need to be adjusted or looked at that the audiologist would be used to doing on their own if they were in person. And a challenge right now is that the EHDI program has assumed the maintenance costs. We have an agreement. We're in the process of doing a legal agreement with Cape Cod Hospital. I felt strongly that Cape Cod should not have to, incur any fees to be doing this. This was a project that we had suggested that we approached them with. And they were very generous with their time with us. And I did not want them to feel like they had to then have a financial obligation towards it. As we're working on the agreement, there may be some parameters, once we talk about new equipment, there may be some shared costs, but for now, the EHDI program is paying for calibration or any sort of small things that come up. So, it's only been in place since this grant. So June of, I guess last year, 2021. So we are much newer and are still learning through this process. And here is my contact information.
Great, thanks, Sarah. That was wonderful. There's a question in the chat box. So hi, Sarah. Given my years of living in Massachusetts in the past, as you alluded to, health systems have a flagship hospital or two, and some further out in the suburbs. Do those health systems already have internal remote services or remote sites to dial into the hub facility? If yes, I assume it is limited, but could it be a good platform for scalability? If no, why not? Would you agree this could help streamline billing, logistics, and other elements you listed on your details slide?
So interestingly, and Boston Children's is one of these facilities that does have a lot of physical sites across Eastern Mass, really. And to my knowledge, they don't have those types of remote services where, say, the the specialist at the Longwood site is going to somewhere further, the North Shore or something. But it's absolutely something that I'm sure that they could consider. It's not up to me to tell Boston Children's what to do, but these are all possibilities. And I think as people get more comfortable, with the idea of tele anything, I think they're more open to these possibilities. Like I said, pre-COVID, there really wasn't any telehealth in our state. I think most folks felt like we're small enough, we don't necessarily need that. And we are very lucky, we're very fortunate in our state that we have a lot of providers. We have a lot of, even pediatric diagnostic audiologists. So that need necessarily hasn't been sort of forefront in people's minds. I think
So another question from Melanie Morris. Amazing project. Any tips on developing a relationship and getting buy-in from the hospitals to partner with them?
So that's a great question. And the relationship part is so key to this. The great thing about working with Cape Cod is they knew that it was an issue. They saw it in their families. So it wasn't something that we were going to them and saying, hey, we have this big loss to follow-up rate. They already knew it. So to come to them with a potential solution or a potential partnership, they were more than willing to partner with us on that. So for those folks that might need a little more, just they might be a little more hesitant, showing them the data and then talking to families, I think is the way to go. Bringing the family voice into it. Again, with Cape Cod, it's this, they know folks don't like to leave, cross the bridge. So in other areas of the state, people say, well, they're used to traveling a couple hours. It's like, you don't have to. And so I think the more, positive experiences that families can share, I think that would make a really huge difference with professionals, to them to actually be able to see the results from these programs.
Great. Any other questions or comments? This is really helpful. Thank you again for Melanie. Would you mind putting your email in the chat?
I'll do that, sure.
So, okay, other questions? If not, we're going to switch gears a bit. And Kira Kirschner is a parent of Cyrus, who is a child that has hearing loss and has been getting early intervention services through telehealth. So far we've been talking about diagnostic audiology, but there's lots of different telehealth applications. And so Kira, we'll turn the time to you to tell your story.
Hi, everybody. I'm Kira Kirschner. My son Cyrus is here with me, so bear with us. He likes to make lots of car noises and he's very chatty. So yes, but so our journey didn't start in Utah. We're in Utah now. He attends Sound Beginnings at Utah State University, which is a LISL program, for those of you who aren't familiar with it. And so we started out in a very rural state, Montana. We're from Bozeman, Montana. And we didn't have a lot of services. And that was a huge constraint on development, especially because we were going with a listening spoken language model. we didn't have a single LISL certified provider in the state of Montana, and I still don't think we do. So telehealth really opened up doors for us. We were able to work with Utah State University, their telehealth program for their LISL telehealth program. It wasn't through insurance, but it was super affordable, $25 a session. And that therapy really opened up enormous language potential and possibilities for our child. And we just saw a growth, an enormous growth of language with those sessions. And I was able to get, it's okay, buddy. It's okay. We'll clean it up after. Yeah, it's okay. We were able to get more parents in Montana who wanted the same service connected with Utah State. So I don't know if you ask the provider who's giving those telehealth services, she has an enormous Montana clientele just because those services don't exist in the state of Montana. So enormous possibilities with telehealth to give those rural states and those families opportunities that they don't have. Another telehealth service we've utilized is a telehealth educational audiology service, and that has been wonderful. That's through Utah State University as well. And we're working with Dr. Callie Merkel, and my husband and I get on a phone call with her and we talk technology. And I'm sure you can all relate, being audiologists and being in the field, that it's really hard to talk to parents at an appointment about all the different types of technology that exist. What is that? That looks like a gate. And it's hard to talk to them about that technology when you're in the appointment and doing ear molds and you have a screaming child and all of those things. So I have found that service wonderful because we're able to talk about benefits of the different hearing aids that'll be best suited for my child. And that's been wonderful. And she uses the Here to Learn platform, heretolearn.org, and they have a lot of educational videos. I'm sure a lot of you are familiar with that too. But that's been super helpful. And I'm glad to be here because learning about the remote ABR piece is really exciting. I just think about my home state. I think about Montana and all the loss to follow-up that happens on the reservations. And even within our hospital system, Bozeman's not a small, I wouldn't call it a small city, but we have one pediatric audiologist, and fitting clients in was a huge challenge, even getting him identified. He was identified at 2 months, but that took a lot of pushing and scheduling, me being pushy as a parent to get him in and get him to make sure he was within that 136. So yeah, I think that's very exciting. So kudos to all of you that are working on that.
Okay. Thanks, Kira. One of our goals with this roundtable today was to give you all more ideas about the different concrete ways that telehealth is being implemented. And Kira has, I think, really broadened that in a number of ways. And so that's been extremely helpful. Any questions for Kira? If not, let's move to Brant Culpepper, who is the EHDI coordinator in Georgia.
Thank you, Carl. And I'm going to try to share my screen. Can y'all see our map?
No, not yet.
No.
You're making progress.
Can you see it now?
And it's there. Yes.
Okay, great. Every platform is different. And I get confused. So thank you very much. I'd like to share just a little bit about what we're doing in Georgia. We fortunately have had teleaudiology for infant assessment services in place since about 2017, which actually was before I took the EHDI coordinator position in Georgia. And in 2018, we were successful in getting Medicaid to approve reimbursement, which has been a huge push for us being able to expand the program. The initial collaboration that we had with the state EHDI program was with the audiology department at Children's Healthcare of Atlanta. And they have been incredibly supportive and incredibly patient while we've worked out the system. The way we operate that is we have 18 different health districts in Georgia for our 159 counties. And if you look at this map, this is showing where we have diagnostic facilities available to do that infant testing. So obviously we have a huge area right around in the Atlanta metro area where we have quite a few facilities that are available to test our babies that need follow-up. But then outside of that metro area, we have Augusta, Columbus, Savannah, and Valdosta, where we do have some pretty well-established pediatric audiologists that can do the infant assessments, but we have huge areas of the state that we really have no services, that parents can drive 4 and 5 hours one way just to get to see a pediatric audiologist. And we know you put a baby in the car, they sleep, and they're not ready for testing once you get there. So we've really gone through and targeted areas in the state where we have a large population that doesn't have infant assessment services available, and also where we have a large loss to follow-up because our families can't travel. So in around 2020, right before the pandemic hit, we were able to start partnering with Georgia Mobile Audiology, which has really expanded our access to our families and access to locations. Georgia Mobile Audiology is run out of the Department of Education, and they're run through some state funding that is targeting, they're providing gap services for not just the EHDI program, but also for educational kids who are deaf and hard of hearing in schools. So they go from 0 to 22, whereas we're essentially 0 to 3 or 0 to 5, however you count it. But we've been able through CHOA and Georgia Mobile Audiology to expand to 8 locations now to provide teleaudiology services. And we're seeing now about 15 to 20 families per month for the assessment, which is really helping out and hopefully is going to have an impact on our loss to follow-up. So lessons learned as we've gone through and done this. Do your homework up front if you're considering implementing teleaudiology. The more time you put into it before you get started, the better your outcomes will be. Go ahead and address any concerns, decide who owns what paperwork, who supports the equipment, all of those things you've heard about beforehand. One thing that we found extremely helpful is use the tools that have already been developed. The infanthearing.org has a wonderful website with some checklists that you can go through. And even though we've been doing this for a while, I always refer back to those to see, have you forgotten something or have you not discussed something for this location? Those are great to have. And then before you start a new site, make sure you do a trial run or 2 or 3 or however many you need before you bring a family in that you have concerns about that baby's hearing. We actually started out testing babies who had risk indicators that had passed the screening, but we still wanted that diagnostic. So we didn't have huge concerns about the hearing status or the hearing sensitivity for the first few babies we tested. One thing we learned the hard way, train more than one facilitator on site. We had a site up and running in the southern part of the state that only one person was trained, and she went out on medical leave and the whole program shut down for a while. So now we're training at least 2, if not 3 or more people at each remote location. to do. Don't expect all of your problems to be solved for access through teleaudiology. If you have patients that have trouble getting transportation, even though it's closer, they may still have transportation issues. We've been very fortunate. Again, Georgia Mobile Audiology has a nonprofit partner that they can actually pay for a Lyft ride for some of our families to get to the location for the services. So even though we're that telehealth model, our families still have to travel to where that equipment is. So there's still that transportation piece that needs to be addressed. And I was trying to think of something that I haven't talked about before. And the one thing that I came up with is when you're looking at the remote location, pick a room that's larger than you think you will need. Because by the time you get 2 monitors, one to monitor the parent and one to do your testing, and you get the crib and you get the parent and you get the facilitator, maybe you have an interpreter. The more space you have, the easier it is to get the right camera angle. And it really helps to not be in a cramped space and have to kick the crib and wake the baby up as you're moving around or things like that. And then one other thing that we found in some areas that has improved a little bit through the COVID pandemic, but we're seeing that most of our parents are buying into this program fairly easily, but we still have a lot of work to do with educating some of our providers about the benefits of telehealth and telemedicine. Melanie Morrison, actually, who asked the question earlier, works with our Georgia Mobile Audiology program. So I was interested to see, she essentially asked the same thing. We do have communities and areas in the state that just aren't as receptive to teleaudiology as other areas are. And so that's an area we're really continuing to work on. So we're excited to see how it's going to expand. We were fortunate also to get one of the AMCHIP grants for COVID that allowed us to put EHDI equipment in Floyd County in the northwestern part of the state. That's allowed us to expand there. And we hope to keep it up. We're hoping our numbers are really going to improve now that it's taking off. And thank you so much. Here's my contact information if anybody would like to get in touch. And good luck.
Thank you, Brant. That was
Thank you.
wonderful. Before I ask others if there are questions, I have one for you. I think it's fascinating that your experience has been that it's easier to get parents to buy in and participate than to get physicians to buy in. Do you have any hypotheses about why that happens and suggestions for how to solve it?
We're working on it now that parents are more familiar with the virtual platforms. It's a piece of cake for most of them. We do have some sections of the state that I don't think it's really, we have different cultures in different parts of the state. And in some areas of the state, they want to do it themselves and not really be involved with public health. And so that's where we see, or at least I've seen, some hesitancy or resistance because the providers are not referring to the public health program for much of anything. But our parents like the ease and it's less effort for them, less expensive for them. And they seem to be accepting it a lot better than some of the providers. And I think we just have some folks that are, they want to see people in person. And we know it's different virtually. I haven't cracked that nut yet, though. And Mel, do you have any suggestions? Please feel free to jump in as well.
Yeah, no, you covered a lot of it, Brant. I would say the different cultures in different parts of the state is a big one. So some pediatricians may not realize the EHDI process. And so they might not understand that they actually need a specialized type of testing that doesn't exist in their community. Because right now they tend to refer to the local audiologist, but those local audiologists don't provide this test. So then it goes to them, and then those audiologists then refer out. So it's, just kind of slows down the process. But yeah, I would 100% say that parents have been so support. I mean, they have been just incredibly happy with it. So it's been going well.
Hi, Oliver.
Well,
I know. I have a baby in the background.
We have certainly seen other areas of EHDI programs where parents have led the way in both innovation and implementation. So let's keep counting on parents. We have quite a few parents on this call as well. So that's great. Paul Summer from Massachusetts had another hypothesis in the chat. He said, one hypothesis is that parents are mostly millennials or Gen Z, and physicians may not be as technically inclined or may have medical records fatigue. Then he said it's also more work for clinicians and less work for parents. So before we judge physicians too harshly, we maybe ought to think about some of those things. So other questions or comments for Brandt? All right, well, this has been wonderful thus far. We've saved the best to last, right, Jessica?
I
So
agree with that, Carl.
we're now going to turn time to Jessica Messersmith from the University of South Dakota.
Hi, everyone. So Brandt earlier, when she made her comment about trying to think of something that she hasn't said before, that was kind of my goal for today as I was thinking about what I was going to present to you. As probably many of you on here have heard me present about our work with our teleaudiology program in South Dakota. So I really tried to come up with some new topics to share that maybe you haven't heard me talk about before. So first, just a brief background of South Dakota, get a little bit of familiarity with where we are. So here's a map of the United States, that little black outlined state up at the top center there. That is where South Dakota is. In South Dakota, we are a very rural state. We are actually one of the few states that are termed a frontier state. To get that designation, you have to have a population density of less than 6 persons per square mile. So South Dakota is a very rural state. We have a very limited number of pediatric audiologists, and we also have very high poverty rates in our state. Every county in South Dakota is designated in full or part a health provider shortage area. So we have some really great needs in our state for being able to be creative in serving those families and those persons who live in some of those more remote areas of our state. We always kind of joke in the winter in South Dakota, it is like the worst combination of all things, if you will, for some of those families in some of those poorer counties, and that they're facing poor road conditions to drive someplace because of snow and wind. They are facing limited financial resources to be able to provide or pay for gas or take time off of work to travel for appointments. And before we started our telework, they had to drive hundreds of miles to be able to see a specialized provider. So we have, over the last several years, worked to set up remote sites in our state. All of those kind of operate out of the University of South Dakota. That is our spoke site, and that is indicated by the star there in that lower left-hand corner of the map of South Dakota. In South Dakota, most of our population, we have a state population of, wait for it, around 850,000 people. That is smaller than most cities in your states. That is our total state population. But most of that population is housed in that lower southeastern corner of the state. So most of that population is there, and then the rest is more sparsely populated across the remainder of the state. So we here are again in that populated corner at the University of South Dakota. And then we currently have 3 remote site locations set up in our state. And those are indicated by those kind of gold circles on the map. And those remote sites were selected when they originally established based upon loss to follow-up rates. Those were counties with higher loss to follow-up rates. And we cross-referenced that with counties, excuse me, with lower household income. So we really tried to target those areas of the state with greatest needs. So through this, we have set up and have established a remote infant assessment program using a hub and spoke site paradigm. And we're pretty well established in this. We had a lull during COVID and immediately after, but over recent months, we've really picked up steam. I haven't updated this recently for April, but in April, my memory is that we had 4 babies that we saw. Which for many of your states, you'll think, oh, that's not many. In South Dakota, that's a fair number. In South Dakota, we have, based upon our birth rate in the state, we probably have an estimated 50 children with some degree of hearing loss born in our state in a given year. Most of those families, again, since that population is primarily in the southeast corner of the state, can get to us, or we have a couple of other pediatric audiologists in our area. So our facilities here see the bulk of these 50 babies that are born per year with hearing loss. So getting 5 to 6 babies per month at these remote sites is probably capturing a good number of those babies that are born out in those areas of the state, just given birth rates and incidence rates of hearing loss. So that's a really quick history of where we've been. What I wanted to give an update on today is where we're going next. And as we're working to set up these next directions, some of the challenges that we are facing. So I apologize, that's really tiny and poor font. That was not a good choice. I am sorry for that. So I'll read those. I usually don't read a slide, but I will read them. The first item that we've been considering and really trying to minimize is the impact of noise in the test room at the remote site during ABR testing. At our remote facilities, they are usually in a local community clinic, but they really could be anywhere. They could be at a school, they could be at a library, they could be wherever works best for that particular community. And our remote sites, they are not done in a sound booth, which means that we're dealing with the noise in that room and the surrounding area, persons in the hallway. And at the current time, we don't have any good data sets on the impact of ambient noise in the environment on these ABR recordings. So we've been working on that to try to identify how much noise is impacting those results, as well as how to minimize the noise in those environments. And I'll show some data on that here in just a moment. We are also working to expand our remote locations to be set up for cochlear implant programming. So in addition to our infant hearing assessments, we would be able to do device programming for persons with cochlear implants, as well as expanding to Osseo integrated devices. So things like your Bajas and your Pontos, being able to do programming of those devices at those remote facilities. A longer term objective for us is to establish mechanisms for doing verification testing with cochlear implants and those Osseo integrated devices at those remote site locations. That is at the beginning stages and is going to require a much longer time period to identify how to implement that in a way that is user friendly, excuse me, while also providing valid results. So I did want to show, these are really busy data slides, so I apologize, but I pulled these from some of our work that we are kind of wrapping up right now in terms of our impact of noise. I'll describe through it what it is. What we see here is 2 different test frequencies. Left-hand side is 500 Hertz stimulus for an ABR. Right-hand side is 2000 Hertz stimulus for that ABR testing. Within each of those sides, we have air conduction as well as bone conduction transducers. That black bar that you see in each of those, that is the consistent replicable identification of a wave 5 in that particular frequency and that particular transducer in different levels of noise, ranging from quiet to a 70 dB noise. And really what I want you to take away from this is when you look at that black bar, as the noise gets higher, our reliability in picking out a wave 5 decreases. And so that reinforces what we assumed to be the case, which is that if you are getting into a room that exceeds about 55 dB of noise in the ambient room, you need to be concerned about that ambient noise impacting the identification of wave 5 in that environment. And 55 dB of ambient noise is not very much. We all know that. Easily in any room, we will be exceeding that. So given this data, and actually I want to point out one more thing before I say that, you'll see also that 500 hertz stimulus is much more impacted by that noise than the 2000 hertz stimulus, which also makes perfect sense. So we in our testing locations now are working to identify ways for assessing the noise in those environments before we initiate testing, so that we can ensure that those conditions are appropriate to be able to proceed with testing and identify whether our results are valid and reliable in that particular environment that we find ourselves in that day. In terms of cochlear implants, we are working on getting our remote locations set up with the hardware and the software to do so. While going through that work, we did a quick study to see how common tele-CI services are across the United States, and the quick answer is they're not, which reinforces our need to do more of this. When we look at the tele-CI services that are provided in the US right now, the most commonly provided services are counseling and troubleshooting. Very few centers are providing tele or remote cochlear implant programming, validation testing, or verification testing, some of those objective measures that you can do during cochlear implant programming. One thing that we found interesting in our data as we've been looking through this is when you break the United States up into regions, cochlear implant services are more commonly provided in the Midwest areas of the United States compared to the other regions of the United States, which again makes sense when you think about that composition. The Midwest of the United States tends to be more rural. If you compare the Midwest to other areas of the US, the Midwest has a much higher percentage of the landmass that is considered rural. So those areas of the United States are going to likely be at higher need of identifying how to do this. As we have been working through setting up our remote CI programming at our sites, we have already, we're relatively new into this, we're about a year into working on this. We've already identified some challenges that have been more difficult than anticipated to overcome. One of those is working through a mechanism to access our network databases for the programming software. So for cochlear implants and hearing aids, when you're programming them, they have to be connected to a software on your computer. And for most audiology clinics, you have that software connected to some type of centralized database that you can access across a range of computers. So regardless of which computer you see that person on, you're going to be able to pull from the same programming. In South Dakota, we're fortunate, this is a benefit of our state, is that all state entities, from the university to any state health care systems or facilities, if it is a state-owned or operated entity, we all operate in the same network, which means we can put our database theoretically in a location that we would be able to access from any computer that is on a state operated network. I say theoretically because that's actually the hurdle that we've been trying to work through, is working with our risk management team for the state to identify a path for us to do so that we can see these families regardless of what remote facility they may come to, or regardless of whether they come to see us here at the University of South Dakota. an example of why that's particularly important. At the University of South Dakota, we are the largest university in our state. So many of our remote kids, when they graduate from high school and start college, come to the University of South Dakota for that secondary education or for that higher education. And they, through being a university student, receive services at no charge from our clinic. So we want to be able to have the seamless transition of that data from the programming software so that wherever they are, wherever they're being seen, we can have access to that. We're also working through the validation testing, so your sound booth testing and your speech perception testing. There are many centers that are affiliated with research practices that are working on creating these tools, but a key to make them clinically applicable is to make them easy to use and to minimize the equipment needs of them. As we know with our remote sites, these sites don't have sound booths. They don't have audiologists. We're working in quiet rooms. We have to be able to identify and develop mechanisms for doing that types of outcome testing that's necessary in the environments that we have available to us. So that was just a kind of a quick update on some of the things that we've been working on. Hopefully it was new information for many of you, not just what I typically talk about. So there's my contact information, and I am happy to answer any questions that anyone may have.
And Carl, you are on mute. Bound to happen to one of us at one point.
Well, I'm glad it was me. So thanks, Jessica. That was wonderful. And you certainly presented some information that was new to me. So I hope it was for some of the others as well. Any questions or comments from Jessica's presentation? Brant?
Hey, this is Brant, and Jessica, I love seeing the information about the noise in the room. Is that in a form that you can share with us so we can share, or is it pending, or?
He's submitted for publications. Yes.
Thank you.
Other questions or comments? All right, so our goal was to present information that would give you some new ideas about things that you can be working on. We hope that you will leave this roundtable with at least one idea that may push the boundaries in your area a little bit, wherever you are along the continuum of using telehealth technology to improve services to infants and young children who are deaf and hard of hearing. I think we've seen a lot of different ideas here, and hopefully that will motivate all of us on this call to go out and shake up the world just a little bit. I want to share some resources that are available to help you to do that. So let me start though by playing just a short video. So, whoops, did I share my screen? It doesn't look like it.
Yep, we are seeing your, it looks like your whole Mac screen. So your background and then your PowerPoint window.
Okay, wait just a second. That's not what you're supposed to be seeing. So let me stop and I'll try it again. Now, are you seeing a PowerPoint with a little boy?
Yes.
Okay, good. So Kira's presentation reminded me of this. This is a little boy that was receiving services through Utah State University. He's a little older here. I want to play just a 1-minute clip of a tele-intervention session with Alex that I think will give you an idea of just what a powerful technology this is. So the clip I'm going to play was when Alex was about 8 months old, before he received his cochlear implants. He was wearing hearing aids at the time as a part of the test to get ready to get a cochlear implant. And this is not a scripted early intervention session. It just, we happened to be filming it that day. And so watch this. Whoops.
Hi, Alex. Hi. Looking up. So why don't you just present the sound, Nancy, and then we'll see if he, has any reaction, just to your voice. No choice. Just you should present this first. We'll see if he looks and starts turning to you or anything like that. Perfect. Awesome.
Looked right at you.
Awesome.
Get a toy?
Yeah, so he looked up, so he can the reward.
Whoa. You've never done that before.
He shoots, he scores.
Yes. That was amazing. That is the really.
So just an example of how exciting telehealth technologies can be for both the participants as well as the people who are providing services. We actually did a randomized study at about this time where we randomly assigned half the children to be in telehealth and half the children to be in in a regular in-person visit, and found to our surprise that telehealth was actually a more effective way of providing services. Children in the teleintervention program actually made more progress than children in the in-person visits. I think there's lots of things that contribute to that, but it does emphasize what a powerful technique this can be. If any of you have any questions, hop in. If not, I'd like to share with you some of the resources that are available to assist you in implementing telehealth programs. So any other questions from people for any of the panelists? Okay, so you should now be seeing our website on the screen share, are you? Okay, good. So this is the infanthearing.org website. If you go to this, right now on the home page, it has expanding telehealth to improve EHDI systems. You can get to the content I'm going to show you through this box, but those boxes rotate. So up here under the resources tab, it will take you to this page. And here is the telehealth information. We have information there about teleintervention services as well as teleaudiology services. Several years ago, we had some money from the Daniels Foundation to develop some short videos, teleintervention 101 for families, providers, and administrators. And if you're considering the implementation of a teleintervention program and haven't yet gotten started in it, I would recommend those training videos to you. This teleintervention guide then goes into a lot more detail about equipment and procedures and billing and all of those sorts of things. What I want to focus on today more, though, is this section on teleaudiology, since that's where we've spent most of our time today. And this was funded primarily with money from AMCHIP through the CARES Act, and provides a lot of information for people who are just getting started. There's a number of videos here related to doing remote infant ABR, cochlear implant mapping, hearing aid programming, site selection and training, and privacy and security, some of which was touched on by our panelists already, but this is information, and some of those panelists are actually the presenters on these videos. So it gives you a step-by-step process that you can use if you're just getting started. But in addition to that, then there's resources here first on organizational readiness that talks about what kinds of things you need to do from within your organization to get started. As you can see, there's lots of links here to additional information. Then there's a section on licensure, reimbursement, and legislation, and some of the issues that need to be addressed in setting up a program in those areas. There's information about making sure that however you set the program up, it'll be done in a way that is consistent and appropriate with professional standards and protocols. A section on teleaudiology equipment, technology, and privacy. Section on teleaudiology training and how to set that up in a way that will ensure success. How you can best prepare families to receive teleintervention service or teleaudiology services. How to evaluate your program to make sure you're having the impact that you want to have. And then providing family-centered communication and support. So, and then finally, a section on using quality improvement for procedures to make sure that your program continues to improve. So as you can see, there's a lot of information here on the website that can guide you in moving from wherever you are now to where you would like to be. Okay, any questions as we wrap up here?